наших гостей из-за рубежа, но те, кто из России есть, мы всех будем рады видеть. Спасибо большое.
Спасибо большое, Виктор Александрович. У меня есть такое предложение. У нас следующие доклады тоже посвящены, в общем, этой же теме. Все вопросы и обсуждения в конце этих вот еще оставшихся 2 докладов, если не возражаете, для экономии времени. Или есть желание задать вопрос? Поступим так? Хорошо. Спасибо большое.
Tal, I promised you before I will block any question to you, but it's not working. Sorry about it.
The funny thing is that I don't think the RIBOA is the solution. I think the EVTM, the concept, is the solution. Just some words about it. Victor, a great presentation, and I think Victor is doing amazing work because we usually tend to show only the success, the heroic fenestrated graphs and how we did great things. This is very good to show when it's not always going and to analyze what's the reason for it. I think it's amazing. Just to summarize, what do we know, and I'll try to touch some aspect that you spoke about, Victor. There are a lot of case series that started from 54, and everybody can read about it. And there are some reviews about the issue. There is some very interesting analysis of Johnny Morrison of potentially a non-compressible hemorrhage treatment with RIBOA of British soldiers. There are some animal studies done, and there are some human studies. The aorta study, that is a prospective American study of the RIBOA, that is done by 8 centers. Joe Dubos is the main, is holding in this, and it's ongoing. This the ABO trauma registry that we are trying to have good collaboration with other centers, and the direct Japanese studies. I can tell you shortly, the aorta, they published preliminary result. They had 47 of 48 RIBOA and compared it to thoracotomies, and there was no difference. And the Americans have now prospectively 104 cases, if I remember correct. It's ongoing, and it's a beautiful study, and we will see what it will show, but it's expanding very, very harshly in the US. It is on clinical use now. The registry, I don't call it our registry, it's a cooperation with different centers, and we try to collaborate as much as possible. I think it's important. And it's open to join. And the number 61, this is the last time we summarized it some months ago, and now we have a PhD student that is working on it. We have almost 100 patients, and the majority are retrospective patients. Now we have around 28 prospective. And what I can say is, in general, that the majority are blunt trauma, a lot from Japan, which means there's a lot of difference how you treat, what are the mechanisms, etc. And what I can say that most of them were done by blind access, most of them in zone 1. We know that in the majority you get an increase of the blood pressure, and it's a real increase in blood pressure. And they're going through a lot of other procedures. When I analyzed the 61 patient, we had a mortality of 52%. And this is the mortality around in the 88 or 98 patients we have now, maybe a bit worse, but it depends a lot on other issues. We know from human studies that it's doable. We know that the mortality at least is not worse than thoracotomy. Is it better in penetrating? I think it is, but we don't have any evidence yet. It highly depends on the institute and your resources. It's apropos the Japanese don't have so much trauma surgeons, so they have to rely on their radiologists to solve the problem. That's one maybe of the reason. Relatively few complications. There are complications, but relatively few. We know that there is severe metabolic effect in prolonged RIBOA, and this is a major concern. And we know from the registry by now that partial inflation has better results. And this will come soon, published soon, I hope. This is a study we did with pigs. We did a total RIBOA, 60 minutes, like Victor did, 60, 30 minutes non-RIBOA, 15 minutes non-RIBOA. And you can see interesting thing about the lactate on the right side. And if you can see, it's obvious what we anticipated. The lactate is riding to heaven or hell, or how you call it, and it compared to time points. If you have less time riboa, you have less lactate. This is the same with pH, the acidity. More riboa, more acid. And of course, we took a lot of interleukins and different inflammatory parameters, and they all showed that the more time you have the riboa, the more negative reaction. This is a model we did a while ago. This is the partial riboa. This is how the lab looks like. And this is the rescue balloon, the Japanese 7 French balloon. This is how it looks when it's total riboa, and this is how it looks like Victor showed with partial riboa. And this was controlled in the following way. This is the blood pressure itself, less interesting. It was bleeding. It's a bleeding model. We took them down to 50 millimeters mercury, and then we let them adjust. And then, I can point. On the right side, you would see the mesenteric artery flow. This was our control. When you do a total riboa, there is no flow in the SMA. Partial riboa, we could see the flow. And non-riboa, of course, there is a flow. This is the pH. If you got the total riboa, of course, you got worsened results compared to partial riboa. And this is lactate on the right side. And you see the lactate was also higher in the total riboa, and it took time to stabilize. I think this is the main issues. There are a lot of other parameters like the calcium, etc. But we can say like this, the time is essential. And the ischemia reperfusion is a major problem. You get acidosis, hyperlactate, hyperkalemia, and the more you use the riboa, the more you will get it. And when you take down the riboa, you think that everything is okay, but of course it's not okay, because now you have other problems. And a lot of patients, both in the registry, as Victor tells, the problems come later. And this is the problem you have to think about very early. It's possible to target your systolic blood pressure with the riboa, and I think it's a major issue. If you get a patient, he has a 50 systolic, you get him to 80 or 70, and then you can work on this time. This would be beneficial. Aim to decrease the riboa time would be very beneficial, as I said. And one thing about riboa, that you can control it, which you cannot do with aortic clamping, or it's very hard to do. It goes in the EVTM concept, as I said, so I don't believe in riboa. I believe riboa is just another tool in this concept. This is the example I showed you before. How to do riboa and what do you need? You need to have a vascular arterial access. This is the main thing. If you don't have access, you don't have riboa. It's very simple. We use always the common femoral artery. We use also the vein for other things, but you can do it from the brachial or axillary. It's a bit more complicated, but it's possible. You need a puncture set, and you need an introducer. Soon it will come, the 7 French introducer to Europe. There are 2 types of balloon, the ER riboa and the rescue balloon from Japan, and there are coming other versions soon also. So again, riboa will not solve your problem. You will get time. How to get the riboa shortly, you can do it in different ways. Most of the surgeons, I would say, if you can get an access directly, just cut down, you go to the anterior wall of the vessel, and then you don't need to do more than puncture there. All these photos are from trauma cases. You can use the access, as I said before, to take blood tests, to have invasive monitoring, to give fluids if you want, to do embolization later on, and of course, if you think that it's appropriate, use the riboa. This is the kit in Örebro, Sweden. We had it sometimes. This is the 12 French and the 11 French introducers for the equalizer Boston Scientific balloon. This is what we have. We're waiting for ethical approval to use smaller balloons. But you need to know what you're using. So you have to be sure that everybody knows, the nurses know what to use, how to use these things. This is crucial. We use the Seldinger method, that you take a needle in, you take inside the wire and work on your wire with an introducer. The anatomy is quite clear, I guess, for everybody, so I will not go into it, but if you're in the vein, use the vein and don't take out the introducer. By the way, sometimes when we don't succeed to go in, we leave the introducer inside instead of taking it out and starting dealing with bleedings. We let 1, 2, and 3 introducer lie there until we succeed. We take care of it a bit later. So it can be a macabre picture with a lot of introducers, but we don't care at that point. This is how we do it. All you need is a needle. I can show here. A needle here, we're using 18-gauge needle, a wire, an introducer, this I think is 5 French, and a syringe. And you will get in. Of course, there are some problems. If you puncture too high, you might have problem after the ilia coming down. And this is an example how it can be a problem with even 5 French introducers. So you have to be careful, of course. This is some beautiful photos made of Lowry to show the exposure. Cut down, the countdown time is around 1 minute in experience, hands width to get in. You get to the artery, and when you get it, then you puncture it under vision. If you have problems, you can even cut it in this situation, but usually we use a puncture. These are some cases done in trauma. Sometimes it's very hard. This was a case that I had great difficulties, a very obese patient, had huge difficulties to come down. So I never said, and I will never say it's very easy or takes just a minute. But in young patient like this muscular man, this is quite easy. The zones, we spoke about it. We're talking also about the no zone, zone 2, which I personally don't agree to it. We have been using it, for example, in iatrogenic bleeding from the pancreas. If you use it by intermittent or maybe by partial, then you can use it in zone 2. This animation of the balloon, just to show how it looks. This is a rescue balloon, and you take it up, and you can blow it up. You can use it in partial or total. In my opinion, this is partial occlusion that is the optimal, but sometimes you don't have any choice. Or use it, take down to the infrarenal and use it there. Also as partial or total occlusion, you can adjust it, etc. Ribot is a tool, and I'm saying it again. The question is if I need it. And if you don't have access, you cannot use Ribot. You have to think about carefully using it. You might perforate the aorta. There is one published case about it by Martinelli, 2010. So I didn't see any perforation, but it might happen. You have to inflate very slowly, and I have to remember, as Victor showed, that it's going like this, like a bubble. When you take it down, you might have a situation that it's just a milliliter or two, and it will collapse. And when it collapses, the patient will have a hemodynamic collapse. And we've been seeing it ruptures quite often. When you take it down, they collapse, and you have to know about it, think about it, and warn your anesthesiologist that it's coming. Partial Ribot, as I see, is the future, and intermittent Ribot. For example, the patient is bleeding, you're doing your surgery, you got some results, and you get a better situation. You can take down the balloon, but we had some cases the patient deteriorated later on. We usually leave when it happens, we leave the catheter inside until we know that the patient is stable, and then we take it out, but you can use it as intermittent. And another thing is hold it in your hands. I don't believe in this putting or suturating it. I think it should be held actively. It's a dangerous tool, and it might migrate and might cause problem. This is an example of partial occlusion done in a rupture case. This is how it looks. And on the right side, this is a case with a major trauma with a clamshell laparotomy. And you see on the left side, it's the Ribot with 11 French. On the right side, 5 French introducer. This is an ongoing CPR with a balloon in place. On the right side, we could hold the patient. There were other problem. The patient was intubated into the esophagus. So our major problem was to discover that it was wrong intubation. Then we could hold him. We knew that we lost the case, but when we did this, we could hold him and could hold the pressure. We're talking about massive liver bleeding, massive spleen bleeding. He had bleeding from the right lung, and we could hold him, get him back to his own rhythm after defibrillation. So we learned here that the effect is substantial. Different ways to do it. What I want to show shortly in this is a great teamwork, because everybody works here on the abdomen and thoracic area, and this person, my colleague, is working on the femoral area that nobody works in. So you have another tool that you can use another person to work on. This is a case we did with partial reborn. We also published it because it was quite beautiful. This patient came with no pulse, 60-year-old guys with Lucas, ongoing CPR, and this is how it looks when we take him in. He collapsed. We managed to take away the Lucas with the balloon, took down the balloon, he collapsed again, and then we were holding him, a resident there holds him with 2 hands on the rebois. We could adjust his pressure to around 80, 90. Then we could do X-fix, laparotomy, packing, and all the procedures, and he's home. So he survived this. And with this, we learned that you can use partial inflation. You can target your systolic blood pressure. Some more tips. Again, I repeat that rebois is a bridge to surgery. It's a living entity, so you have to respect it, hold it, take care of it. And use, of course, partial occlusion if possible. And be aware of the second hit, what happens when you take it down. And it's tool. It does not replace surgery. It's just a tool to help you. This is a patient here with a knife trauma, and you see the C-arm at the side, and here is the angio table. So it does not disturb you. You can use it if needed. Thank you so much.
Thank you very much. Thank you very much. We shall leave for the discussion at the end. So I introduce the last lecture by Boris Kessel that I think everybody in the audience know. And I asked him to do the last lecture that I think is something comprehensive regarding the previous one, and after we open the discussion for all